finally, we are going to the last several topics now. I hope you are not too tired because I think H90 may be not that familiar with you guys, but I would like to introduce some of the concepts that we are improving and we are increasing in this kind of treatment. Okay, this is Taipei 101 if you have been to Taipei. So I will start with the HCC in Taiwan. Actually, it's almost the same in Asian countries. So it's the fourth most common cancer and second leading cause of cancer-related death in Taiwan also. We have like 47 HPV and 33 HPV infections. But we are rising trend on non-B and non-C now. And because we have now, since 1984, we have the vaccine to decrease the HPV infection. So we have like regular ultrasound and alpha protein checkup for every 3 to 6 months if you have HPV infections. So the treatment of HCC modalities in Taiwan is almost the same worldwide. So we have like early HCC, we will provide like surgical resections, liver transplantation, and RFA. But for intermediate and late HCC, we perform the local regional therapy as today. In the afternoon, we have talked about the TACE, the DAPTase, CTACE, and now we have the radio transarterial embolizations. It is growing, but not yet reimbursed by the National Health Insurance. And also, I will have another topic, talk about the HAIC, the chemo infusion. So, but we have some challenges for interventional radiology because we have increasing the systemic therapies. So we have the current, we have like sorafenib, lenvatinib, and Rigel, and other second line of TKI, and also increasing of the immunotherapy, atazolizumab. And future, I think combining the systemic therapy might be the future to survive as an interventional radiology. So I think we should have systemic agents plus local regional therapies. I will share some of these concepts later. And also, I think the role of radioembolization and the HAIC is going to be increased also. So the radioembolizations in Taiwan, for the indication we usually do for the unresected liver tumor, and also for only confined to the liver disease, and to preserve the liver function, and sometimes failure for other modalities. And the cost is still very high in Taiwan. It's self-paid. And I think we are still growing for this kind of treatments, especially for patients now candidate for liver transplant. And also, if it's not alternative to TACE, we will shift to radioembolization. So this is the the radioembolization indications in HCC. As you can see, from stage A to stage B to stage C, there are roles for the radioembolizations. So Taiwanese studies now for radioembolizations, we can see that for tumor response, we can achieve the objective response rate to 55.4%. Complete response rate up to 22%. And the downstaging success is for surgical intervention, almost 14% of patients can downstage to undergo resections or other local regional treatments or transplantation. And for overall outcomes, the median overall survival is 1 to 4 months, and 12-month objective response rate is up to 73%. So, and also, I would like to emphasize the quality of life. For some of our patients choose to do the radioembolization because it can improve the quality of life. So the patient will experience fewer procedure complications and have better overall quality of life and less side effects. So they might have like a little bit of abdominal pain, nausea, or decreased appetite. And for our own study, only 6% of patients will have radiation hepatitis and pneumonitis, and only 2 patient deaths related to radioembolization because of the advanced disease and comorbidities. This is the radiation pneumonitis. And this is how I do the radioembolization, because I don't know if you have any experience. We might think that radioembolization might take a long time to get to be treated. But now I usually have the first day for admission, then at the first day we usually do the CT to analyze the liver and tumor volume. And then for the second day, we will do the mapping for the TCMA to make sure if the patient can do this treatment. And for day 3, we have to predict the dose of radioembolization, H90, to see if there is lung shunt fraction and if their tumor or normal liver ratio is appropriate. And for day 4, if the patient is suitable, we can perform the radioembolization on day 4. And if the patient is not suitable, we have other local regional therapies, and also we can shift to systemic therapy. And day 5, if the patient didn't experience any uncomfortable, and the patient can be discharged. So it only took me 5 days to do the treatment. So now I would like to share some of the clinical scenarios. What kind of the patients you can perform radioembolization? For scenario 1, this is the most scenario I like to do because the patient will get cured or really improve the outcome, because we do the downstaging for operations by doing the selective or super selective radioembolization. So we don't have to do like a prophylactic embolizations, or we don't have really care about the non-shunt fraction, because we only do a little bit segment of the liver. So it's quite safe, but we have to use really high dose of radioembolizations to do this. So this is a quite big tumor, about 8 centimeters, and at the beginning, the bilirubin is up to 8. And actually, the patient lives in Vienna, and he's Taiwanese, and he fly back to Taiwan. So we perform the radioembolization. Okay, you can see the tumor. So we have calculate the liver volume, the tumor volume, and then we perform a really high dose of radioembolization. So you can see I super select to middle hepatic artery, left hepatic artery, and right hepatic artery. After the radioembolization, you can see the shrinkage of the segment and also the tumor. So the patient had the chance to get operation, and then the necrotic tumor mass is about 6 centimeters and only 1.3 centimeters of viable tumor. So this is a really complete response case. And another one, you can see almost 15 centimeters of the tumor. When we see this kind of really big tumor, what kind of local regional therapy will you perform? Like DAPTase, CTase, or like combined with systemic therapy. Now we use lentase, for like really quickly necrotic the tumor. Either will do, but it depends on what modality you have. Then we also perform the H90. The patient, and we also have a 1 time of day that takes to decrease the size of the tumor. Then you can receive the operation. So I really like this kind of treatment because the patient will get improved. And the scenario 2 is the radiation segmentectomy. For this kind of patient is also good because it is not candidate to the surgery, but we can do like a radiation segmentectomy. We don't surgery, but we can have like a shrinkage, a tumor shrinkage of the segment. So it's not, the patient is not candidate for surgical due to his comorbidities or poor liver function. Then this patient has performed 4 times of TASE, but there are still a tumor located in segment 4, about 4 centimeters. Yes, we super select to do the treatment. So we super select to the second and fourth. And we have a high dose of radiation. Also, this is a complete response case, total necrosis of the tumor. Scenario 3 is more advanced. Multiple HCC without vessel invasion. For this kind of scenario, due for palliative or prevention disease progression, so we have to maximize the tumor dose, but minimize to preserve the liver function. So we can perform this kind of radiation, and the patient will have chance to do more local regional therapies. This is an 86-year-old female with, I have so many large HCC for tumor up to 10 centimeters. Then what should we do? You can see hypervascular tumors under the angiography. Then also we perform the radioembolization because the patient is too old. It decreases the complication and better the quality of life. So you can see the radioembolization, the E290 uptake very well. So you can see the PiYi and the alpha fetoprotein. For a half-year follow-up, you can see the alpha fetoprotein back to normal. But actually, there will be still viable tumors or tumor recurrence. So the patient was quite satisfied. So we performed another radioembolization. But what happened? Shunting, right? So we have to close the shunting before we perform to decrease the side effect. So I have closed the shunt. And then I performed the second time of E292. So the patient still lived very well. Scenario 4 is coming bad and bad. So HCC with vessel invasion. So for this kind of tumor, I think maybe you have this kind of experience. You do the radioembolization, you don't get a better outcome because most of the time you started with this kind of situation with portal vein tumor invasion. So you don't feel like a good experience about radioembolization, right? So for this kind, we have to do multiple treatments and we try to downstage this kind of patient, but sometimes we don't have good results. So this patient is very young, only 56 years old, but multiple with main portal tumor thrombosis. So I tried to perform the E290. I have done for 4 vessels. It's quite a tired job to do that. But you can see the follow-up. The patient, the tumor decreased vascularities, but I think cirrhosis also will happen because we damage the liver. Okay, for scenario 5, sometimes we have patient receive operation but tumor recurrence, but he has no chance to do another surgical treatment. So this patient, 55-year-old with multiple tumor recurrence, and we perform the E290. You can see after the treatment, only one viable tumor due to the vessel supply from GBA. So we have to we forget to treat the GBA, so we have to do it again for depth taste to control this tumor, but the other tumors are disappeared. Okay, another one patient is that the patient had recurrent tumor with really small one, but we still try to help him. So we have super select to each vessels and doing super selection radioembolization. Yes, the tumor still responds well, but lymph node, pleura metastasis, no metastasis. That's why we usually don't have good experience for really advanced HCC. And we also do for liver metastasis. S colon, sigmoid colon with liver metastasis. The patient has received operation once, so you can see the myeloma. So after drainage the myeloma, we have do the radioembolizations for the tumor. Then the follow-up shows that only a small part of viable tumor. So the patient received operation. So she got cured due to the radioembolization and operation. So after this kind of like discussion, I think there are still some like technical challenges we should be aware, because we need the nuclear medicine doctors to tell us, how to calculate the dosimetry. So actually we all usually see the hypervascular tumors and we see the contrast medium, but the nuclear medicine doctors see the particles, see the bright region of the liver. Yeah, so we have to communicate with the nuclear medicine doctor. It's a multidisciplinary discussion. Then we calculate for the dosimetry. But this is another story because it's a lot of knowledge. So I'm not going to discuss today, but we have to give adequate dosimetry, and we also have to be aware to decrease the side effect. Before, I think maybe if you have to do the radioembolization before, we usually at the beginning do the conventional approach. We calculate the tumor, we calculate the liver, and then try to make sure that we have the high dose to the tumor. But nowadays, we do the segmentectomy and lobectomy. Then we don't have to do really careful careful the TN ratios. We usually have high dose to the segment. That's it. But we have to patient selection really carefully, and also for the technique. And so there are some safety and efficacy of the dose we should be aware. And also, as I mentioned all the time, we do the super selection now, because if we can do more super selective, we can prevent some kind of side effect to the purge of the radioembolization, and we can make sure we have the H90 into the tumor. So for improvement of radioembolizations, carefully patient selections, the indications. If we have good indications, I think sometimes the surgeon will think that, yes, you can do the downstaging for me. The patient will have the chance to get operations, liver transplantations, and I think that's why we are increasing the radioembolizations nowadays. And also, combined therapies is very important too. Now we have immunotherapies and TKI. So I think combined therapies, it plays an important role for every local regional therapies. And also for the radio and thyroid doctors to communicate with the clinicians. And also to standardize the protocols. That's why we usually have consensus for each kind of treatment. So for the future, I think maybe we should do more ongoing trials, and we have more radio embolization technologies, and also for the immunotherapy combinations. So in conclusion, radioembolization nowadays, it has the effective tumor control because it has high rates for tumor response and local control and reducing the tumor size. And also it improves the survival. And patient will experience the better quality of life. And we try to downstaging for the patient to have a chance to have liver transplantation, surgery, or other local regional therapy, and to enhancing the long-term survival. And also, personalized dosimetry is important too. Now we usually do the precision treatments for interventional radiology. Yes, this is how we do the radioembolizations, and by doing improvements of our treatments, improve our devices, improve our technologies, and for interventional radiologies, where precision means better care. Thank you.